Thank you. All right. Good morning, everybody. My name is Kelly Sandaker. I am the administrator for the SUDISA Safe Supply and SURSAC. I'm administrator for all three groups, and I'm here with you today. We're doing the work group, and I'm going to start off reading some disclaimers and guidelines. Disclaimer: this meeting is being recorded and will be posted to the HCA website, a webpage dedicated to the SUDISA work group. Please begin recording. Michelle's already done that. This recording is open to public disclosure. Please do not disclose any private or confidential information. Guidelines for public feedback. This group is not subject to the Open Public Meeting Act. Members of the public are welcome to attend and observe the SUD Intake Screening and Assessment SUDISA work group meetings. Meeting participation, including use of the chat, will be limited to work group members unless otherwise specified. Guest participant, panelists, presenters, etc. If you are not a committee member and would like to provide comment or question for the work group consideration, please email hcaesb5476 at hca.wa.gov, and the work group administrator will share your message with the work group. All right, today's agenda, I emailed it out to everybody last night, so everybody should have the agenda. Real quick. As always, I like to share the SUDISA SharePoint page, and we have a new page called Reports right there, clicking, but this is how you get to everything that is SUDISA for the SUDISA work group. All right, next. All right, so I'll be talking to everybody today about the difference between the report and what we're going to be going over today for this Word document for the ideas and tracker. So first, I want to show you everybody this. This is what I sent out on Monday, and this is the rough draft that's being sent up towards legislation. And I'm not going to go over this or anything like that. That I sent it out so everybody could have time to go over it, and if they had any questions. There will be time if you have questions about this report that myself or someone can answer. But these are the final recommendations. We're not making any more additional recommendations. That these are it. This is the report that goes to legislation. And then what we have here is what was done in the very beginning of SUDISA, called the SUDISA Idea and Consideration Tracking. And so this was created. It didn't have all the nice color coding and everything. And so these are desired outcomes or recommendations we put on the mural, or we put them in the very beginning and wrote them on the Word document. And what happened was I categorized each number. I categorized under desired outcomes met with recommendations, meaning the recommendations I just showed you guys. Desired outcomes met with ACM. Desired outcome met with SPA law or DOH. Desired outcome did not move forward. Statement with no goals. So we had some stuff that was like someone had put, and I didn't delete nothing. Everything's been exactly the same since day one. But some people had wrote statements like, golden thread's not the best. That's a statement. That's not really like golden thread is per the agency and everything. That's, and so though that's a good thought and idea, and if someone wants to expand on that eventually in this work group, they definitely can. So the idea today is that we would go through each of these and determine whether or not basically if I was correct and how I color coded them. And I would want to hear what people had to say on each of these. And some of them are pretty self-explanatory, and you can sit there and some of them need some context. For instance, I'll just give an example, and then we'll start off with number one. But ensure that pairs are not a barrier to access. This was a reference to inpatient. So some people might read this and be like, well, no, pairs can still be considered, a barrier to access. And though that might be true, I don't think the goal of the group was to obliterate like all barriers to access to care through payers, and so it was more looking at inpatient. And so I put under that the work group agreed that SB 6228 will answer this desired outcome. And that's how I saw it. And when we get to it, we'll be going through number 5 as well. I'd like to hear anything from the group on each of these ideas and considerations tracking. And then what happens is that ones that are flagged as red, and we do have some that are I marked as red, we will see if the group or something how internally we could handle that recommendation without I want to say legislative piece, but we'd see how we can move the recommendation forward, and maybe not necessarily in a report. The report's done. We're not doing another report. So this group wouldn't do that, but this group could also come up with different ideas to how to move progress forward with one of these recommendations. Michelle, do you feel like I gotten everything, or do you want to add on something?
No, I think yeah, that makes sense to me at least. Does anyone have questions about that?
You can just raise the hand, and I can call on you. All right. I'm gonna have my chat open, and I'll be seeing raise of hands as well. Michelle, if you can, if I don't notice someone's raised hand, if you can point it out to me, that'd be greatly appreciated, just in case. But I'm gonna go ahead and move forward, everybody, and start with provide recommendations that are expected to broaden the workforce capable of administering SUD assessments. So one second, I like having this up just in case I don't get nothing wrong. One second. Okay. So as you guys know, we completed this item with recommendation item number one, which is that's the whole idea behind recommendation one, which is increase the Medicaid managed care rates so that with the direct goal of um, with hiring more folks with at a higher payer rate and such. And so I put down recommendation one covers this. Is there anybody that feels different? Want to turn this to a different color? Want to make this red? Keep it?
This is Brandy. I vote keep it.
Okay, great. Is there anybody else that feels like it should be any different? I mean, this one's pretty straightforward. I'm glad this is the first one. The second goal, I'm gonna go ahead and keep this. And when I put keep there, I'm gonna put a notation. Keep means that there was no real discussion that everybody here was like, yeah, we all agree, Kelly. Like we can move forward on to the next one. So design a screening or assessment process that is brief, low barrier, and person centered, including only what is necessary to manage utilization and initiate care. I mark that as blue, being accomplished by the ASAM fourth edition. All right. Yep. If everybody, just so you know, if you go to React, if everybody wants to give me thumbs up when you see something that's thumbs up, like you agree, then go and give me a thumbs up. If not, you can just raise the hand. All right. Next one, recommend expansion of specific services that can be provided prior to the completion of assessments. I said that we completed, they didn't, whenever we wrote this, uh, I don't know what expansion of services they were specifically talking about, but I said that we completed this with recommendation number three, because that's where we're asking for peers to be able to complete services before diagnosis and assessment and treatment plan and everything like that. And so I said that it's number three. Can I get some thumbs up or a hand raise? All right. See some thumbs. See some thumbs. Okay. Medications, MAT started prior to the assessment, so patient can be stabilized first. So I put we completed this with item. So this is already being done, I believe. It's already being done. Wish Tony was on because he actually made a note about this recommendation. But the medically assisted treatment is already being started prior to the assessment. But I also said in recommendation number two, we want to do an education campaign around facilitating more education of doctors about medically assisted treatment and how we can start it sooner than later. And so I put that we cover this under recommendation number two. Any thumbs up or hand raises or anything? Thumbs up. I got some thumbs up. Any hand raises? All right. Remember, for some reason, I did this document. You guys should have access to this, but if you don't, I'll make sure you get access to them. If you're feeling a little bit something different after this, and you're taking some notes or something, and you're like, you know, something, Kelly, I really feel like number six in the first category. I feel really strongly about it. I don't think we really answered it. Here's the information. I'll go and take that email as well if you feel like you need more time to process it. Ensure that pairs are not a barrier to access. I said the work group agreed that SB 6228 will answer the desired outcome. Any hand raises on this? I get some thumbs up. Hmm. Thank you, Meta. I went ahead and I put a slash. I put MAT/MLUD. Yeah. Um. Okay. All right. So this is where it gets a little tricky. So what happened was when this document was being created, some stuff got repeated, and you guys are going to see some things that are repeated. However, some of the verbiage is like a teensy bit different, and so I didn't delete nothing on this document. And so I did put this. I feel like this is a duplicate, and so I want your guys' opinion on what it means. But that's just I'm just putting that out there. So if you're like, "Well, Kelly, this looks exactly the same as the other one," I am still not going to delete. I'm going to this document. I want to keep it going, so I'm never going to delete anything. If I end up taking away anything away from this document, I'll strike it out. So allowing peers services to happen before diagnosis. I said this happened with recommendation number 3. This is the same as number 3. And then I'm gonna put these together. Peer services provided before intake. We completed this item with recommendation item number 3. This is the same as item number 3 and 6. Any discussion on these hand raises that they think that maybe these aren't the same or anything? All right, Meta.
Hey, are you just gonna change it to one that says allowing peer services to happen before diagnosis/intake or something like that?
No, I wasn't. I mean, I can add that just because, like, that's what I think the context was of it. So some of these were written without completion, so I think it's good to add it. But I'm not gonna. They're gonna stay the same. Like they're gonna stay number 6 and 7. But I'm not gonna combine or anything. I'm just gonna
Oh,
if
okay.
it. Yeah, I'm gonna keep them for right now, and then yeah, just in case if anybody else looks at this document in the future and they go, well, actually, I think like maybe this might be what they're talking about, and so yeah. Thank you, Meta.
Kelly, this is Eliza. I just want to make sure. So when we completed this item with recommendation item number 3.
Mm-hmm.
So allowing peer services to happen before diagnosis intake. I want to make sure that we have like how we addressed that recommendation because I'm remembering that we really couldn't recommend that except for like one service because of the state plan and whatnot. So I want to make sure that that was captured.
So I thought with recommendation 3, what the goal would be
Mhm.
is that certified peer counselors before formal SUD assessment intake is completed, that they'd be able to provide outreach services, and that it would become Medicaid billable, and that it was a recommendation. That's what I thought the recommendation was about.
So, yeah, but I think that I think though there was a lot of discussion about how it currently is, right? Like so peers can do peer services like as
Mm-hmm.
crisis services after the initial crisis. And then there's also the behavioral health care coordination and community integration that also allows for peers. But other services like specifically peer support it would require like state plan and all of those things that and for safe and effective care because peer support specifically would need to be recommended by a mental health professional after the assessment unless in a crisis or behavioral health care coordination or integration setting. So I recall that conversation kind of happening on repeat. Maybe I'm wrong, but I just want to make sure that we're clear in what we're recommending within limitations of what can actually be done, right?
Yeah, so I mean, what the final recommendation when I'm reading from the report that's already been submitted and everything like that is that the work group recommended expanding the availability of Medicaid billable services provided by certified peer counsel before formal SD assessment intake is completed. This includes implementing behavioral health care and completed integration services in various settings such as emergency departments and homeless encampments, expanding Siri language regarding peer support to include transition from community-based settings, homelessness, and emergency departments under the community support care coordination umbrella would allow non-inpatient staff to provide assessments. That's kind of what I have written. So is that not,
Mhm.
so does not like the spirit of like what we're trying to say in that recommendation is that someone could get peer services before an assessment or diagnosis?
I think that it is. I just remember we were really wanting to be careful about how we were going to word that and offer it. So it seems like it was captured, but I just want to have that in the back of our minds.
For sure.
Because I
No,
know
thank
there was
you.
a lot of feedback. I know I put a lot of feedback on the draft about that.
No, I appreciate that. Do you feel like that this should be turned red temporarily and we should come back to it?
I definitely am open to others on the group. If I'm misunderstanding something or if there are questions about that, I don't want to make the sole decision. I just wanted to highlight it as because that was one that like that and the telehealth obviously were a big like they had significant conversations.
Yeah.
Because there was stuff already in place or there was limitations or whatnot. So I don't want to make that decision necessarily for the whole group, but
Yeah, for sure. But are you suggesting that we maybe bring it up to the group?
Yeah.
Is there anybody else in the group that would want to turn this red and have a conversation later, or would just want to keep it as is? If you feel a certain way, you can raise your hand, or you can give me a thumbs up for keep. All right, Cara.
Yeah, I'm open to having a further conversation about it because I'm just looking at the draft and I don't see anything in the draft about any wording around the state plan or making adaptions based on that. That's just my thought.
Yeah.
Yep. And also too, by turning it red doesn't make this document bad. I know I used red. Maybe I should have used like a really nice color or something, but all it means is it keeps the conversation going. If for some reason the recommendation 3 turns out that this is answered by recommendation 3, I'll come back in the document and I'll change it yellow. That's all that happens when I turn it red. I just track it a little bit further after the recommendations. That's all. So. But is there anybody that's against turning them red? All right. So this is another one that might turn red as well. Section 3. All right. There we go. Oh, well, I got an 8 there. That's weird. Okay, there we go. All right, so this is another one that might turn red. And so reducing wait list times, and I'm pretty sure this was in connection to like how long it takes to get an SUD assessment or in the ER. I put item number 4 and 2 could possibly answer this remedy, mainly because recommendation number 4 is around telehealth and helping providers expand that, gain knowledge and billing and such, and that means there would be another pool of providers maybe that previously didn't offer telehealth, or maybe they did and they stopped and we're re-engaging them into telehealth. And then recommendation number 2, because we're doing campaigns on assessments not assessments, but doing campaigns to providers about MOUD and MAT and such, and that could also reduce waitlist times as well. And so I put that number 4 and 2 could possibly answer a reducing of waitlist times. Also in number 2, we talk about an educational campaign for Scalia Northwest, which is like their whole thing is to get people engaged with services while they're in the ER. So, but raise the hands if we want to change this one, or I mean, if we want to keep it. Raise the hands if you have anything to say about it. All right. Can I get thumbs up? Everybody's cool with keeping what I put on there? All right. greater accessibility and availability of mobile intake to serve people who can't leave where they're at. So again, remember, when I look at these, I was just kind of thinking like, well, maybe it could, but this might be one that turns red. I said about the last one, so I don't know. But I said we completed this item with recommendation number item 4 because with the expansion of telehealth and such, I think that it would give greater accessibility to people. You don't necessarily have mobile intake. It does have its own thing, which I think that's why it could be red. But also too, like I recommendation number 4, you could do telehealth and get someone's services, but they would still have to leave their house. So I don't know. I'd like to hear from some people on this for sure.
This is Eliza. I mean, I think we have to be, again, kind of cautious about telehealth being intake. So unless, remember, it would need to just be video. It would need to be video, right?
Yeah,
Like they could not do it audio only. So that's
for
just
sure.
the one that we want to make sure is clarified. But nonetheless, yeah, I think it could potentially go in line with number 4.
Anybody else have anything against me just keeping it? Can I get thumbs up? All right. All right. This is one that I think will be a good discussion for us. So I put this as purple. So again, so we haven't had a purple one. Statement with no goal. This kind of does have more of a goal in mind, but me and Eliza talked about this and we kind of didn't understand it. And we did some research and we were like, oh, I don't know what happened there. I don't know what happened, but and so it says diagnosis preliminary treatment can be established before impacting other factors. Full assessment / 90 days allowed to complete full biopsychosocial assessment instead of 14. I basically put this item makes little to no sense. There is no WAC or SIRI item that prevents an SUD assessment happening at 14 days. The work group unpacked this and agreed to remove it from our list of recommendations. I still kept it just in case there's something someone wants to bring this to me, or bring it up to the group, I mean. And so, I mean, there is no requirement for 14 days. The requirement is that before services initiate, an assessment has to be done. And as far as unpacking, I mean, yeah, I mean, that's all I'm going to say on this. But we looked in the WAC and SIRI. There's nothing about 14 days for an assessment. This also could have been, someone brought up, this could have been a contract requirement for a specific provider that's within this work group that has some language with the MCOs or some insurance company around 14 days and assessments and such. That could also be why this is where it is. So, Brandy? Oh,
Sorry, I had needed to unmute myself. Yeah, I do think there was misunderstandings, at least on my part, from I'm not sure I don't believe I placed this one because I'm not sure I would have listed 14 days, but I do believe that some of the MCO contracts, especially for inpatient services, require a full assessment and ASAM update to be sent in for authorization. I think that's been reduced to 3 days now instead of what it may have been for some programs, 14 days. And so I do think that's more in line with payers and funding than it is WAC requirements. I also think that if you wanted to add it, that, I do think that the ASAM changes, the 4th edition, is going to improve that as well. And it kind of depends on how the WAC may change regarding, the assessment that's needed for treatment versus treatment planning.
yeah. Yeah. Eliza?
Yeah, I think it's important to also note that there's 2 legislation pieces that potentially impact this, right? So in 2021 there was the 2642. So it eliminated any prior authorization, but that meant for withdrawal management in 3 calendar days and for residential in 2 business days, and it's like medical necessity would have to be proven and assessed so that level of care could continue. What 6228 has now done is says if that medical necessity is met, an authorization has to be for 14 days. And then at 14 days, the payer has to authorize a minimum of 7 days. So there's some pieces from those two legislations that specifically reference, well, 6228 specifically referencing the 14 days, but I wonder if that kind of was an interplay. And then there's also 6228 that has the work group that's currently recommending a universal authorization form. So all payers have kind of the same expectations. And part of that is going to be, utilizing the ASAM criteria for that assessment piece. So just wanted to highlight those elements.
And Eliza, the 6228 is the one that does 14 days in the beginning and 7 days for every authorization after that, right?
Correct. Yep. And it
Okay, good.
incorporates the legislation from 2642, just to emphasize that hasn't gone away. That's still
Okay.
expected, but now here's what's the next piece of that. For residential, there's withdrawal management does not have the 14-day because of the nature of
That'd be
withdrawal
cool.
management.
That'd be cool. Yeah, that would have been cool. I'm gonna keep this still, everybody. It's everything I'm keeping here, and I'm just updating with some notes and stuff. And I'll put maybe a little more information later, but basically just the conversation we're having here. Does anybody feel any type of way about needing to change? I'm checking the chat too. If there's a requirement, MCO contract to complete a full. Eight.
Oh yeah, I
Sarah,
was just asking because we have an MCO rep on the call that maybe they can check their contracts or maybe they know offhand. I think Katie's on, but if
Yeah,
not, we
I'm
can
here.
follow up over email.
I can check our contract and take a look.
Perfect. Thank you.
I can also make a note here. So as of right now, is everybody okay with me keeping this purple? Is there any reason that it needs to be red or anything like that, or changed back, or it's answered by another recommendation? All right, can I get thumbs up? This is okay. All right, outstanding. All right. The people are getting the services they need and want. So to make sure, so ASAM has made some changes to the dimensions, and dimension 6 is really about getting the person's input about what level of care they. I just went through my ASAM training. It was very, very enlightening and interesting. So dimension 6 is very much about the person wanting that level of care and what services they think, and making co-decisions together and such. Is there anybody that believes that this should be read or changed or anything by any chance? If you do, just go ahead and raise your hand. Oh, I just raised my hand by accident. All right. Can I get thumbs up if this one sounds cool? All right, I got some thumbs up. People are getting connected with the support in the moment, especially with outreach. Difficult to follow up with people. So I said we completed this with item number recommendation number 3. I can also with stuff I put down for recommendation 3, I can track it as red right now and follow up back, and that's all it means is I'm following back up with it and seeing where we're at with it all. Is everybody okay with me turning recommendation 3 stuff to red unless we really feel strongly about it? I mean, not a big deal to me. And track. All right, definition of recovery support services are broadened to cover harm reduction services. The DOH will examine this in the future in 2025. Unless somebody has, I mean, that's pretty, I mean, I pretty much put this is definite, like, gonna happen. This is a DOH thing. So, does anybody else have anything to say on this one? All right, thumbs up for keeping it. Okay. Establish uniform standard of requirements. County requirements vary so much. I think we already talked about this, but 6228. Eliza, you said 6228. They're coming up with a it's just for inpatient, right? The authorization form you're talking about.
Yeah, it's inpatient and residential. And the reason that residential is included is because the name of 3.7 currently
Mm-hmm.
is residential. But yeah.
Okay. I think that this established uniform standard requirements, how I remember this coming up is that this is like about the insurance. It came up very much about inpatient, I believe. And it's basically like the requirements of, authorizations and stuff is how I remember it being brought up. If someone remembers something different, because I had to go back and watch the videos because I missed like the first 3 meetings I just started. So if anybody remembers anything different or if they want me to change this, just go ahead and raise your hand and we can talk about it. All right, can I get thumbs up? All right. Redefine recovery support services to include harm reduction services. This is the same as number 13, the DOH. We'll examine this in for future in 2025. Can I get a raise of hands? Anybody that disagrees or wants to, not disagrees, but maybe wants to talk about it? All right. Can I get thumbs up for keeping it? All right. All right. Create an assessment that is less burdensome, including only essential information needed to get some people through the door to services. I said this is being answered by ASAM 4th edition. I see raise of hands for anybody. All right. I get thumbs up. All right. Shortening the process to get into desired services and limited options available to offer people coming in the ER. I said we completed this recommendation with number 2 because of Scalia Northwest. We recommended giving education to emergency rooms on Scalia Northwest so that more people can get service. And that, I mean, granted, that's only one. I want to make sure this is clear. Scalia Northwest does not help someone get into inpatient. They help out with MOUD. So it's for opiate use disorder. So it is a limited population for that. But in recommendation 2, we talk about educating providers, all that kind of stuff. So I mean, if someone feels a little bit different, especially if you work in an ER, if you feel like this should be read, I do have a red ER thing a little bit down the ways, but I'm just saying that if you think this one should be read, just raise your hand and let's talk about it. All right. No raises. I'm gonna turn this one red as well. So I'm tracking all recommendation 3s so that we see what shakes out at the end, and then I'm gonna compare after recommendation 3 hits the legislation and they do what they do. I'm gonna see how it shakes out and what happens, and then compare it to these notes right here. And so I am putting recommendation 3 into reds, and it just means I'm gonna track it, which I think is a good thing for this. So change to red. All right, providers can initiate medication prior to assessment process, MAT. I will change this to mound. Because sometimes medication itself is enough to stabilize an individual long enough to conduct an assessment and ensure greater chance to follow through with recommendation services. I said this is the same as number 4. I said that we completed this item with recommendation number 2 to give more greater education to providers about how they can provide MAT and MOUD before they even go to outpatient and such and all that. So, any raised hands on this one? All right, can I get some thumbs up? All right, outstanding. Pairs support clients' access to care and not barriers to care access. The work group agreed that SB 6228 and ESBHB 2642 will or did answer this desired outcome. This is the same as number 5. Does anybody agree this is different from number 5? This is number 5. All right. Can I get thumbs up? Getting people the services they need and want. Looks familiar. This is being accomplished with ASAM 4th edition. Actually, and this is a repeat. I'll go back and find it later, but we've already said this once through the documentation. Dimension 6 is being changed. So anybody disagree with that? All right, outstanding. Being able to connect with people with supports that needed in the moment, especially with outreach, difficult to follow up with people. I put recommendation number 3. Like I said, I'm gonna go do this so I can track and see what happens with all these. All right. The ability to complete SUD assessment via audio in certain situations. You can raise your hand if you want on this, but DOH will be going over this in rulemaking in 2025. Good to keep track of this. So if you are somebody that is really interested in this, I'm gonna try to reach out to DOH and find out who might be in charge of this. I think I already knew who's going to be in charge of this, but um, and reach out. I'll reach out to DOH and find out what month we could find out when the rulemaking could be happening or such, and I can let you know. If you want to put your name in the chat or email me, I can find out that information for you. You can also, just so you guys all know, there's a way to sign up for information being sent to you from DOH or HCA. So what is it called? Michelle, what's that thing called? The Gov system, the thing where you get the emails, like what we do with the listservs. The listservs. You can get listservs through DOH and ACA. They'll let you know about this information. Did I get it right? Is it the listservs, Michelle?
Yeah,
Gov
yeah, it's
delivery.
like it's like being on HCA's email list, for different kinds of programs and updates. Yeah, you can be very specific about what you want to get updates about, and this would be one of them.
Yeah, and so but is there anybody that wants to speak on this? All right. Our next section, current barriers, general considerations to note. What are the desired outcomes? Screening assessments are used differently within medical primary care setting versus BHA. I said in recommendation 2 that we're taking care of this because I feel like we're going to be able to do some real good education with providers and stuff. Oh, thank you, Eliza. I super appreciate that. If you guys check the chat, Eliza had put the Gov delivery sign up. I really highly suggest everybody gets on it if you're not already on it. It gives you can pinpoint information you want. You'll get updates about certain things. It's a really good system. I work for the state and I get emails about the work groups anyway, but there's some stuff in DOH I like to know about, and so I'm signed up on the Gov delivery stuff to know about certain, especially like SUDP rulemaking. If I want to know stuff about my licensure changing, I'm signed up for Gov delivery and I can find out what's happening. So screening and assessments are being used differently within medical. I said recommendation 2 is answering this because we're going to be able to talk providers, but I will say this in recommendation 2, there's no actual specific thing that says that we're going to talk about language versus like inpatient and medical settings and behavioral health settings or anything like that. If they have questions and we're already doing the educational campaign, obviously we would try to give resources and give education, but that won't necessarily be the goal. So, but I put it yellow, but this can easily be changed to red and it can be tracked about later on how we can do this. Any raise of hands? Would ever be cool me changing it to red and just tracking this right now? Thumbs up? Okay. All right. Okay. Assessment link has a lot to do with the follow-up paperwork that takes place after the direct engagement with the patient, jumping through hoops to get paid based on who the payer is in each situation. I believe this was inpatient. The work group agreed that SB 6228, ESHB 26242 will or did answer the desired outcome. This is the same as number 5. When I say number 5, yeah, number 5 up here. It's basically talking about payer information. Any raising hands on this, or can I get some thumbs up? All right. Higher rates of trauma mean more thorough assessments are needed for appropriate treatment recommendations. I put this as being accomplished with ACM 4th edition, because when I went through my training, they did talk about how the ACM 4th edition is going to be looked at as more through a trauma-informed lens. So that's just my opinion and what I got from the treatment. But if anybody feels any different, go ahead and just raise your hand. I got some thumbs up. Anybody else with thumbs up? All right. Screening appropriate for urgent care needed, i.e. detox and assessments are more appropriate for determining longer term course of treatment. I put this as being accomplished with ASAM 4th edition. Anybody want to raise their hand? Can I get thumbs up for keeping it? All right. Currently, paperwork required to get someone a detox is so burdensome that it has become a significant barrier. With the ASAM level placement of care, I feel like this is gonna change things. So everybody, thumbs up for this. You can also raise your hand if you feel like you want to speak up and say anything about this recommendation. Okay, I got some thumbs up. Great. Goal and thread doesn't work for everyone. This is a statement, no goal established. If somebody, I'm not saying you have to, and certainly right now, but if for some reason, if you read this and you want to get back to me, I mean, goal and thread is not written in the WAC, right? Goal and thread is an agency specific thing that, like when I worked at every agency, yes, every state I've worked at has done the goal and thread. But that's an agency requirement. And so, which I find to be beneficial, but some agencies might not. It might not benefit the patient, right? It benefits me as a paperwork person. It definitely does. But if anybody wanted to say anything about this, I'm going to keep it no matter what. But if anybody wants to speak on this, you can raise your hand now. All right, can I get some thumbs up? All right, good. I see some thumbs up, Gary. Make sure we have facilities that roll out for them to understand and implement new policies and required timeframes. I might have got this one. Hey guys, I got this one kind of wrong. I think I read this incorrectly. This is not answered by number 4. Number 4 has to do with telehealth. This doesn't have anything to do with. Hey guys, so I'm actually I'm gonna figure out how to strike through that, but I'm gonna change this to red for right now. I don't think this is answered by any of the recommendations. I'm gonna strike through this and because I don't want to delete nothing, but yeah, I don't think this is answered by recommendation number 4. That's about telehealth. This is about facilities rollout, and I'm pretty sure this has to do with the inpatient and implementation of new policies and required timeframes. And so, yeah, does anybody feel any different? Want to raise a hand, or you can also give me thumbs up if you agree with me. You don't have to agree with me. All right, I got some thumbs up. I'm gonna go ahead and say change to red. Assessment and variabilities are parts of the problem themselves, not just access. Need to think about how to get a consistent tool point, minimum necessary information before getting them into care. And again, I think this is talked about in the reference of detox and rehab mostly, and getting people in when they need it, or talked about MAT and MOUD and stuff. But I did say that this is being accomplished by ASAM 4th edition. Any raise of hands on this? Can I get some thumbs up? All right, guys, we're making some headway. I do got some good news and bad news. Like this takes all the way to like 24, and then we have like 18 final ones. But the 18 final ones are kind of mimicked what's all up here. So, but we're gonna get through this, everybody. Standardization can also limit a client's ability to get resources they need, i.e., drug and alcohol may be only assessment. They'll be sit for 2 hours. This is a statement with no goal established. Also, too, if there's no goal established, if someone wants to comment and say like how this could be turned into a goal, you don't have to right here on the spot. You'll have access to the document later, and you could think about it for a little bit. But is anybody against me changing this right now? I mean, like keeping it the same. I'm just put keep. Can I get thumbs up? All right. A barrier to treatment access is the taxing amount of time it takes to receive financial approval to pay for treatment. This was talking about inpatient treatment, and I put 6228. Wheeler did answer the desired outcome. Oh, yeah, financial approval to pay for treatment. Yeah. All right. Does everybody agree with this? Is this good? If you don't, you can always raise your hand on any of these. All right. Can I get thumbs up? All right. Outstanding. The assessment length includes amount of follow-up paperwork that takes place, the client engagement. The time needed can increase based on who the payer is within each assessment that is completed. I put that I think the ASAM 4th edition is going to answer this. Does anybody see anything different? Want to raise your hand? Okay. Crucial that assessment recommendations are trauma informed because the trauma is different for each client. Higher rate of trauma means assessment should be more thorough to ensure appropriate level of care is provided. I believe, I didn't mark it on here, but I believe we've said this already. That is being accomplished with ASAM 4th edition. Does anybody disagree with that? All right, if you do, just raise your hand. I can do it. Paperwork that is currently being required to get individuals into more urgent care, such as detox, is very lengthy and need to become a significant time barrier for both clinicians and clients. This is being accomplished again by fourth edition. Does anybody disagree with that? All right. Primary care medical assessment, medical evaluation to determine diagnosis, which could be SUD, are distinction from SUD treatment assessments. I.e., assessment biopsychosocial elements, but DSM-5 criteria are used for diagnosis regardless of setting. This is a statement with no goal to establish. Do I have a raising hand on this one? Okay. Unhoused people who would benefit from treatment are not likely to pursue an assessment, likely to qualify for higher level of care, but then are often long waits. Work group considering housing outside the view of the work group task, however, stated the report should reflect how being unhoused could affect receiving an assessment. And so we did mention in the report about housing and such, but I still kept this as purple because like it's not a final recommendation, I don't believe. It's a other recommendation. And also this is kind of more or less like this is outside the preview of our work group, but we did make mention in our report, but this is how I kind of reported it. Does anybody want to raise their hand or say anything about this one? All right, keeping it. The ASAM criteria assessment, including CARF, JACO, and WAC requirements, is too extensive. In addition to individual service plan requirements prior to first service, I believe an effective screening to access services, including level of care, could be used. Then a full assessment after entering services would speed up the process. There are also barriers to the referral process for inpatient SUD providers. This is being accomplished with ASAM 4th edition as being answered to the recommendation number 2. Because we're providing more education about services and such in recommendation number 2. Any changing this? Raise your hands. Okay. Needing to do an ASAM first was a barrier. New model where medication can be administered first and assessment later works much better, MAT or OUD. This is being answered recommendation number 2. And also, too, you can already do medication first now. That's the thing. So, anybody disagree on this or want to raise their hand? All right. There are also barriers to the referral process for inpatient SUD providers. I think more education around 2642 and more, and then also too, I think 6228. I'm gonna put also 6228. I think is going to help with this too. Um, yeah, I think it'll help overall. But with that form, I think it could help a lot. Is everybody okay with keeping it like this? All right, accessing all SUD services needs improvement. The ASAM criteria and assessment, including CARF and JACO and WAC requirements, is too extensive in addition to the individual service plan requirement prior to first service. So this is partially answered by 4th assessment. This is answered by the ASAM 4th edition, but is somebody else want to raise their hand on this? Okay. 13 plus population able to access care without parental consent. This is a statement, not really a goal to establish. I don't know if they're trying to say that kids are not able to access care right now at 13 without parent consent, or that's how it should be, or what should happen with this. So I don't know what to really do with it. I'm keeping it just in case if anybody gets an idea from this, but does anybody want to raise their hand on this? Okay. Intake and assessment are often used interchangeably, so we need to differentiate the two and distinguish them as two separate pieces of the puzzle, especially considering SUD versus mental health intake versus assessment. So one thing I just want to populate here is that like language that's used in the field, I wish that we could control what language is used within the field, but WAC 24634100200 does identify in the definitions what an intake is and what an assessment is. Whether or not people want to use that WAC in the field, that's really up to them. But that's how I see it. And again, I'm willing to hear anybody that wants to raise their hand, and if they want further more into this, we can turn it red. So just wait to see a raise a hand. All right. Doctors not use ASAM in medical settings went from medical to withdrawal management already in an outpatient program. It really should be purple. Um, I don't know what the recommendation for this is really, and I don't think it's answered by number 2. Anybody disagree that I changed this to purple? Okay. Change to purple. Uh, um, Oh, it's too dark or purple. There we go. Requiring insurance cards before referring to detox and withdrawal management. This is a statement, no goal to be established. Provider gave context about a situation where a detox was requiring insurance card for a patient to enter into treatment. We gave information to the provider of who to contact HD about this. So I was just, this got added on there. And so we're still tracking this and everything. If for some reason this is still an issue for any of you, please put something in the chat or email me and we can have a further discussion about it for sure. I know I worked inpatient. If I required everybody to have an insurance card, it would be awfully hard to take anybody inpatient. So, but keep lack of providers or services is being answered with recommendation number 1 and 4. Number 1 is to increase the Medicaid rate, especially the bed rate, and then also 2.4 is to expansion of expansion of telehealth services that might give us more providers and services being offered. Any disagreement? Just keep this as is. Any raise of hands? All right, 16 bed limit creates bed shortages in residential treatment facilities. We have a 115 SUD inpatient waiver. It includes the 16 bed limit. Medicaid cannot be used for state intuition defined as having more than 16 beds, but the 1115 waiver allows Medicaid funds to be used to facilities with more than 16 beds. So I got all that from the sheet. It was already on the sheet. So does anybody disagree with that? All right, these are all the recommendations. So these were basically, these ones were actually all the same that are the above. So yeah, and I just put already talked about in the above. So like they're written verbatim almost, but they were just, yeah. So they're there. All right. So these were what were on the mural. I think we'll be able to get through these pretty fast because the stuff that was on that paper went to the mural, but I wanted to capture like everything just in case. So healthcare professional can establish diagnosis, probably. So this is the 90-day thing. So I'm now going to change it to answered above if it's something that we've answered in the above recommendations above this. Does anybody disagree that we didn't answer this, that we need to talk about it further? Okay. Established, copy this. Establish uniform standard requirements. We talked about this, and I want to put answered above. Any disagreement? Facilities closing, treatment facility shortage. I don't believe this is answered above. This is being answered the recommendation 1 and 4. Though it might not, I mean, 4 might not help with the shortage, but it could. But recommendation 1 is the real strong one in this one because offering a higher Medicaid rate obviously would give more money to facilities to have more staff and be able to run and everything. I wanted to go ahead and keep this. Is any disagreement on that? Or not disagreement, just want to raise your hand and talk about it? When individuals require inpatient and medical care, um, everybody okay with keeping this? Any raise of hands? All right. Providers can start medication before conducting FCD assessments because medications alone can be stabilized individuals for assessments. This is already being done in the community, so I'm just gonna put keep. Is there anybody that wants to speak on this? I mean, it's already being done, so. All right. Recommend expansion of specific services that can be provided prior to the completion of the assessment. So I put this as a recommendation 3. Mark it as red, and I want to see what's going to happen. So there we go. SUD assessments not being available for 1 week or more, inpatient hospitals referrals to SUD treatment. I said this is being answered by number 4 because if we provide more telehealth options, people will do more assessments, and so that's why I put number 4. Any raise of hands on this one? All right. One issue with assessments is that the treatment centers cannot sometimes accept the assessment already conducted by another agency or organization. Incentive to do it themselves because assessments are billable. Inpatient hospital to SUD treatment. I put this will still need to be worked on. So there is no. The WAC does not specifically talk about taking someone else's assessment and what that means if you're an outpatient treatment facility or if you're going from a hospital to SUD. It doesn't say that we should have a central pool of where to keep the assessments, or if one person accepts an assessment and there's no the assessment's done incorrectly, meaning it doesn't meet the DSM requirements, is that agency now held liable for taking that assessment on and such? And so there's no on this, so it's something that still needs to be worked on. Is there anybody that feels any different, that this isn't something that still needs to be worked on? Okay. Mobile intake services should be more accessible and available to individuals who cannot leave their home. 1 second. I think I lost track there for a second. Okay. Mobile intake services should be more accessible and available to individuals who cannot leave their home. Will still need to be worked on. Does anybody disagree with that? Okay, I got to raise a hand. Alicia?
Kelly, can we go back to the last one real quick? Sorry.
Yeah, no problem.
So I
One
guess
issue.
my
Go ahead.
my main concern with this one, and maybe I'm misunderstanding it, is, this isn't statewide. Not everybody doesn't accept other assessments. So, I just want to make sure that, it's not, I don't think that's across the board a barrier. That's all I wanted to say.
Okay. I can notate that. And remember, by keeping this doesn't mean that this isn't going in any recommendations at this point, right? We're just keeping it on note. At the end of everything that's in red, just to be real with you guys, it could be something that we all meet as a group and we're like, oh, we could do something with this. Or we might meet as a group at everything that's in red and be like, nope, that's still going to be individualized and up to the inpatient. That's going to be up to whatever treatment center does what they want to do, And so, but I'm glad what you said, Alicia. So I'm going to. That's pretty much what you got, right, Alicia? Like, there are some agencies that do accept the assessment from other agencies. Like if you go to IOP somewhere and they have an assessment, you can get the IOP assessment and then go to another IOP treatment center. They might accept that assessment. It's not true across the board. It's individualized to treatment.
Yeah.
Okay. All right. Mobile intake services. Raise the hands on this. Is there anybody that feels like we don't need more mobile intake services? I feel like we could always need more of that, but anybody want to raise their hand on this one? Okay. Smooth transition from ED to inpatient or detox. At our last meeting, I believe someone had brought this up, so I added it in here. And so smoother transition from emergency department to inpatient or detox. And so this is something to be looked at. And is there anybody that feels any different? Like this shouldn't be read? I feel like this is something that's gonna be worked on forever. Like we need I can't wait till there's a system in place where always have a smooth transition from emergency department to inpatient or detox. All right, no raise of hands. All right, I'm keeping it. Fee cap, keep the fee cap longer than a year. This was also talked about in the last meeting. So some of you don't know that if you are an SUDP or you have SUDPs, we fee capped it for 1 year so that the licensure is only $100. And so someone had brought up, is there any way to extend that fee cap? And so that's something we're looking at. So I put it in red and I added it. Does anybody want to change this? Yeah, okay, I didn't think so. Lack of access to treatment based on cultural needs. At first I did have this answered somewhat by recommendation 4, because telehealth services always expands treatment, and so that means more people from more variety of people can access services. So, but after looking at it with an HCA, with some HCA folks and stuff, we're still thinking like this isn't that's recommendation 4 really is not answering that lack of access. And so for based on cultural needs. And so is there anybody that wants to raise their hand on this? All right, guys, we're almost through with this, just so you know. Some clinical, especially FQHCs, will have social workers trained to take on management of behavioral health referrals, but not able to conduct ASAM assessments. General referral managers may not be familiar with referrals to behavioral health services, BHAs, primary care to SUD services. So recommendation 2 in there, we talk about educating the public about, Siri, the billing, the Vidal, who can actually do an assessment based on, if they're trained in it, it's in their scope and such. And there's a lot of people that don't know who can do an SUD assessment, which is it's in the WAC and everything in the Siri. And I actually didn't know until I started this work group how many people could actually do an SUD assessment if they're trained and it's within their scope and such if they're a BHA. So I said this being answered by a recommendation 2. Is there anybody who wants to raise their hand on this? All right. Easy to follow up on referrals once they are made. I think we were talking about peer services. Or no, we're talking about primary to SUD. This one might need to be changed to purple. I'm not understanding it that great. So, is there anybody that doesn't think this should be purple? If not, you can raise your hand and I can keep it what it is. And I don't know if recommendation 3 really answers this, except for that recommendation 3 has to do with peers. So, I mean, but we didn't mention anything about follow up. I mean, yeah.
This is Brandy. I agree with changing it to purple because I don't think that it has been addressed.
Yeah. And I don't know what it's really trying to say here, but I want to come back to it. So I put change to purple. So I'll come back. That's a really dark purple. Okay. Ooh, that's there we go. That's a little better. People are not getting connected with support the needed in moment, especially with outreach, difficult followed up. So I already said I was going to do this. So I'm tracking all of these. Ooh, that's a really really bright red. I think it was more like this, salmon color. All right, got 3 more guys, and then we're me. All right, medication mound started prior to intake assessment. This is already happening. Does anybody else have anything to say about that? We already talked about it previously. Shortening the process to get into desired services, limited options available to offer people coming via ER. Options for when hospital beds not available, ER to SUD treatment. I said recommendation 2 because of Scalia Northwest. We're gonna, we want to give more education to more hospitals about how they could become part of Scalia Northwest and give and offer MOUD as a possible thing, which would shorten the process because in Scalia Northwest, the ER doc agrees to give them the Suboxone or whatever MAT or MOUD the treatment they want, and then they get follow up care out in the community. Brandy?
Although I do agree that MOUD addresses opiate use disorder. It doesn't for alcohol use disorder specifically. I mean, not that Vivitrol, but I'm not saying it's, I can go with what the group agrees to, but I don't believe it addresses fully the options between hospitals, just like primary care, between, the care coordination and referrals are difficult.
No, I can agree with you, Brandy. This could definitely be turned red. Recommendation 2 is a stretch. It only fits a certain requirement of people. So if anybody is okay with it, I think this should really be more like a red. If anybody has any issues with it, and I'll put in a red how come, because recommendation 2 only serves one specific population, though it does maybe reduce or shorten the process for treatment, but that's only one population receives that. Does anybody have any problems with turning it red? All right. All right. And the last one. Oh, wait, no, I think I have another 20 down here. No, I'm just playing, guys. All right, investment the state is making into housing. Oh, this is an easy one. We've already considered housing as a thing, and I said, work group considered housing as an outside the view of us, but yeah, basically that we put it on the report, but it's not within our view. Anybody disagree with that? All right. Well, that the last thing I have for you guys is that our next meeting is October 14th at 1:05 p.m. Before we leave today, I'm gonna stop sharing my screen. I'm gonna go on camera for a second. I feel like you guys haven't seen me in a while. No. Good to see all of you. So just let you guys know, it's been a real privilege being part of this work group. This isn't the last meeting or anything. We still got 2 more left, the 14th and the 30th. But something I wanted to have you guys keep in mind for the next meeting maybe is that there's been conversations amongst us HCA folks that maybe that this group could be utilized further even after the report. We can't necessarily do another report for the next year, but there is agency legislation change recommendations we can make as a work group, and we don't necessarily have to meet at this cadence, twice a month. We could keep the work group, and we can meet quarterly, once every 3 months, and we could take these items that you saw in red and we could take them and have bigger and larger discussions about them, and we could get more ideas, and we could see how HCA folks and people from the community, from providers and everybody, how we could maybe answer these boxes in red, or even answer some of the questions in red, and how we can move forward and everything. And so it's something I want you guys to think about for October 14th, if you think this group can stay together. But also, too, at the same time, that doesn't necessarily have to happen. At the end of all of this, at our last meeting, if you're feeling like the work group has answered the call that was required for the state and everything, and you've done what you feel is necessary for the state, that's okay too. And we most likely we would do a majority vote in keeping the work group or not. So if it wasn't a majority vote, that doesn't mean also too, if for some reason the work group didn't continue, that doesn't mean that we can't have email exchanges or if people want to meet on their own or anything like that. But it's just something I wanted to give you guys some time to think about, and because before we bring it up to a vote or anything, because this is like looking at schedules and all that kind of stuff. And maybe some people are like, yeah, I'm okay with meeting like once every 6 months or something like that. So, um, but yeah, so I mean, uh, I just wanted to give that all to you guys, and I just want to tell you guys how much it's been like a pleasure and honor and everything. The next 14th meeting, we probably will discuss that. Will probably be on the agenda. Depending on that meeting, might determine if we have an October 30th meeting. So for right now, it is still on the books, and so is the 14th. So. Does anybody have any questions for me at this time about any of that stuff? Okay, as always, before I get off, Michelle, do you have anything?
No, all good on my end.
Okay. Anybody from the HCA that wants to speak up at this time?
This is Eliza. I just wanted to say thank you, Kelly, for leading us through the work.
Thank you, especially this last one. Hey, I appreciate everybody that stayed on. Thank you so much. That was that was a lot of paper to get through. We still did it with 8 minutes to spare. So I appreciate y'all sticking it out with me.
Hey, Kelly, this is Maida. I just want to second that. Yeah, thanks for the heavy lift here.
And just so you guys know, I know you don't hear her speak this much, but I also want to give out a special shout out to her. Is she's in the background, definitely helping and making sure that things happen. And she's always a person to answer my questions and everything like that. And she started out with this work group and everything. I just want to give a special shout out to Michelle because she's just been so helpful with anything. If I have any state questions, she just is right there with me. And same with my supervisor, Sarah. Just really helpful, both of them. So I just want to say I just appreciate both of them together. And yeah, thank you so much. And I appreciate this group and everything that we're going through together, and thank you so much, guys. All right. Well, I will see you guys at October 14th. Thank you, everyone. I'm going to go ahead and give you some of your time back. You got 8 minutes. Thank you so much, guys.